Good morning to all of you tuning in this morning. We have folks here today from all over the United States and even the world. So thank you. I even see in the chat some folks checking in from the UK. And so it's very exciting for us to be able to reach such a grand audience in this virtual modality, right? I'm Dr. Jason Bolton, Vice President of Community Partnerships and Admissions for the Help Group. And I will be moderating today's webcast, The Benefits of Psychotherapy for Autistic Individuals. Since August of 2020, we have offered a series of webcasts that have covered such topics as distance learning during the closure of school, how parents can help their students at home, social skills, the mental health impact of the pandemic on our youth, making proper use of neuropsychological assessments, the intersection between autism spectrum disorder and LGBTQIA+, and more. You can find each of those webcasts as well as a virtual open house of all of the schools that we operate on our website at www.thehelpgroup.org/webcasts. Just real quick, I have noticed a couple people asking if we're recording. Yes, we are. I know Erica answered that, but we are recording, and you will be able to find this webcast along with the ones I just mentioned at that site. Another question folks ask sometimes is about, am I on camera in the audience? No, nobody's on camera. Just the panelists that you see up here are on camera, and we can't hear you either, okay? For almost 50 years, the Help Group has prided itself in creating new programs responsive to the emerging needs within the communities that we serve. In recent years alone, we have launched a new school for students with learning disabilities or autism who are interested in science, engineering, technology, and math. We've launched a coaching program for young adults who need support and guidance to enter college or the workforce, and a groundbreaking social support and mental health program for young people who identify as LGBTQAI+, a prevention and aftercare program to ameliorate child maltreatment in LA, and an early detection program for adolescents and young adults experiencing concerning psychiatric symptoms designed to prevent their escalation into a fully diagnosable disorder. In that same spirit of responsiveness, recognizing the increasing mental health needs in our communities and the difficulties many are experiencing in accessing needed services, the Help Group has recently opened the Lumina Counseling Center. Lumina offers health insurance funded and private pay individual, group, couples, and family therapy to persons of all ages, in addition to psychoeducational evaluation and diagnostic assessments. Our goal is to meet our clients where they are and build a strong, trusting, and compassionate therapeutic alliance with those seeking our support. At our core, Lumina Counseling believes that everyone has the right to be heard and to be guided to live their best possible life. Within our Lumina Counseling Center, we aim to provide empathic, affirming services to everyone who is interested in the support that counseling provides. We are here to help people of all ages and with any of the challenges many are experiencing, especially these days, including those who are neurodivergent. Building upon the Help Group's years of experience working with those on the autism spectrum and members of the LGBTQIA+ community, Lumina is uniquely able to work with such clients. With that, I would like to tell you about today's panelists who will lead us in this important discussion about the benefits of psychotherapy for autistic individuals. Dr. Lori Stevens is a developmental psychologist who has been working with children, teens, and young adults on the autism spectrum for over 25 years. She currently serves as the Help Group's Senior Director of Autism and LGBTQAI+ programs. Previously, Dr. Stevens served as the Director of Autism Spectrum Disorders at the Help Group. Her primary area of specialty is in designing social skills curriculum with a newfound passion for the changing nature of social expectations in the digital age. She has designed, run, and supervised social skills groups for children ages 2 through young adulthood. She has provided individual, family, and parent psychotherapy, utilizing primarily a cognitive behavioral approach to a wide range of clients. While working with her ASD clients, Dr. Stevens became extremely interested in the overlap between transgender and genderqueer identifications and folks on the spectrum, as many of her clients began to share their authentic selves to her. She oversees all of our programming and events and has been instrumental in establishing a specialized diagnostic clinic for LGBTQIA+ children, teens, and young adults who may suspect they have an autism spectrum disorder. Dr. Stevens also sees clients in the Lumina Counseling Center. Sydney Frank was diagnosed as autistic around the age of 9 and entered into the therapy at the age of 10. She received a Bachelor's of Fine Arts from Cal Arts in 2015 and went on to work for the Muppets TV show before deciding to make art a personal hobby. She then followed her father into the dental field. Sid is now a registered graduate and works as a dental technician, making veneers and crowns for a boutique dental laboratory. Deborah Frank, whom we will also hear from, is Sydney's mother and an arts advocate in our community. Okay, so you've heard a little bit about us and our presenters, and we would also like to know a little bit about you. You should now see a short poll pop on your screen. Please answer the questions. I'll give you a few seconds to do that. We have learned through this process that when you finish taking your poll, that you will have to X out of that poll in the top right-hand screen, or else that poll will sit there and obscure the views of our faces the entire time. So take your poll. I'm watching the number of people taking it here, and I will summarize the results here in a second. All right, so we have about 80% of you who have answered, but it's still going up, but the results are stabilizing. So of course, the question I asked was, have you attended at least one of our previous webcasts? And about a third of you have, so that means 2/3 of you are new to us. Thank you so much for coming. Secondly, we wanted to know exactly who's in the audience, and we have about a third who are parents, about a third who are mental health providers, a handful of teachers, and then some others as well. That is also about a third. We're interested always about what people's concerns are about their own mental health in the pandemic, and about 2/3 are saying that the concerns have increased during that time, and the rest pretty much have said remain the same. There's a couple of people who have actually said decreased there, but most have said either remained or increased. And then I was hoping people would be very interested in this topic. That would be why you would sign on. So yes, that is what's bearing out here. 90% are very interested. So I'm going to go ahead and end that poll, and remember to hit the X so that it is not up on your screen this entire time. Okay. Well, we are honored that you have chosen to spend another hour with us. And since so many of you are new, I do want to thank you for joining us for the first time, and I want to let you know a little bit about the Help Group. Among other social and mental health services serving the entirety of Los Angeles County, including the Lumina Counseling Center that I just talked about, and our intensive family intervention programs. The Help Group operates 14 non-public schools in Los Angeles County for students with autism spectrum disorders, learning disabilities, ADHD, developmental delays, and emotional challenges. We contract with more than 80 local education authorities, meaning school districts or charter schools or active school districts, to provide special education and related services to more than 1,100 students every day. During this presentation, you may use the chat function. Many of you have already discovered that. To present questions that you would like the panelists to address. We will have a Q&A section at the end of the webcast, and we'll attempt to answer as many of those questions as we can. And as you know, we also collected some questions during the registration process as well. From doing several of these, we also know that we will not get to everyone's questions. So if there are some good salient questions at the end that we haven't been able to get to, we will also reach out with answers to those questions. Now, I have the great pleasure of introducing our expert speaker, Dr. Lori Stevens. At the conclusion of her talk, Dr. Stevens will introduce us to Sid and Deborah so we can hear from them as well. But now, Dr. Lori Stevens.
Hello, and welcome. I'm so glad that we've been able to reach people not just in LA or California, but throughout the nation, throughout the country. So welcome. I want to start off with a really quick disclaimer or disclaimers in presenting this talk, just for everybody to remember that there is not a single voice for autism. So we are talking about a diagnostic category that is extremely multidimensional and heterogeneous. So what one person might need or feel might not be the same as what another autistic person needs or feels. So it's difficult sometimes to talk about or say everybody with autism can benefit from this or that. We really need to look at each client that's coming into our centers as an individual and work from there on deciding what they need. This talk is really based on my nearly 30 years of experience providing clinical services. I myself am not autistic, but I feel like after working for so many years with this population, that what you're going to be hearing today is really the voices of my clients and what I know has worked for them and what they've told me they need and what has benefited them. But also I want to be able to say that nothing that I'm going to talk about is necessarily going to apply to all autistic people. So please do keep that in mind, that something might not resonate or jive with you or your child, but that doesn't mean that it wouldn't jive or work for another person that is autistic. So am I moving slide? Oh, there we go. And just really quickly, I also just really, I want to make sure that we all have the same conception of autism. And I think a lot of people think of autism as this sort of linear spectrum. We all know it as a spectrum. And we think that, you know, you can have just a little bit of autism and you're on one end of the spectrum, and then you can have a lot of autism and be on the other end of the spectrum. But that's actually not at all what autism is like. Like I said, it's really a multi-dimensional condition where we're looking at these specific traits like social difficulties or social skills, communication skills, intense focuses, executive functioning, sensory overload, repetitive behaviors. And anybody can be anywhere within these dimensions. So for instance, you can have high needs in one of those areas, but low needs in another. You might be very able to communicate your feelings, but you might have extremely intense sensory overload that makes it difficult for you to go places or to be able to handle I don't know, a lot of input, whether that's physical input, whether it's auditory input, whether it's visual input. And so if you look at the right hand of the screen, you see that all three, A, B, and C, of these little schematics are autistic people, but they're all presenting differently. And this is why no one strategy works for autism. There is no one thing that I can tell you today that you can say, oh, this will work for all of my clients. We're really talking about looking at the individual that comes into the room and what some of the things are that we know that are commonalities within this population. But again, each person is going to present a little bit differently in that multidimensional scheme. And what's becoming much more obvious within the autistic population is you've got autism, but your actual autistic features might not necessarily be reasons why you seek out therapy as a young adult, as an adult, or a parent is seeking out therapy for their child. It oftentimes is related to other types of mental health challenges. So for instance, recent statistics have shown that about 75% of the autistic population have at least one comorbid or co-occurring mental health condition, and almost half have two or more coexisting conditions. So as a clinician, we want to be aware of that because again, as I'm going to talk about sort of throughout this talk, is are we treating autism or are we treating the other conditions that are what are impacting the client or the individual the most? So the most common co-occurring conditions include anxiety, depression, suicidality, suicide thoughts, or suicide behaviors. And this is something that's new. I think for years this was just ignored, and nobody was really looking at the suicide rate of people with autism. They may have, again, looked at, well, these were depressed people that committed suicide, and forgetting about the autism diagnosis that the person may have had. We also have eating disorders with the autistic population. It's oftentimes what's called ARFID, which is avoidant restricted food intake disorder. And then I think the newest thing that's really beginning to come forward is trauma. And I want to talk a little bit about the trauma. I think everybody is aware of what some of these other co-occurring conditions are. But the thing with trauma is that a lot of times for autistic people, it's not necessarily a traumatic event, like one thing that happened, but more there's systemic trauma from having, let's say, been put in compliance training and kind of been told, well, you have to do this and you have to act this way. A sort of lifelong invalidation of, we need to cure you, and feeling like they themselves just are not worthy, and being traumatized by going everywhere, and these ableist views that they're presented with on a daily basis. And we also know that there's a very high percentage of bullying that occurs for autistic people. So we are talking about years and years of oppression, basically, and of feeling like they are invalidated, which can lead to pretty significant trauma feelings. And this is an area of clinical research that's becoming more and more popular and is new. But I think it's really important to keep that in mind about everything that I'm talking about. And as a clinician, I would really encourage you to explore trauma feelings and trauma experiences with your clients, because they might be there and they might be very strong. So a little bit about autism and psychotherapy. And again, when I'm talking about psychotherapy, I'm really talking about that more talk therapy, if you will, but I don't believe that it has to be verbal, which we'll talk about in a minute. But that's kind of the standard way of thinking about psychotherapy. And historically, people with autism were denied through insurances, and often like through the Department of Mental Health, were denied access to psychotherapy because the thought was, well, autism is a lifelong condition and there's nothing that we can do about it. So nobody could possibly benefit from psychotherapy, because they think that the idea is, oh, psychotherapy is something, I'm feeling anxious, I'm going to go see this therapist for 6 weeks and I won't be anxious anymore. And the fact is we know that that's not true, whether you have autism or not, that oftentimes anxiety feelings can take a long time for you to work around, and that there's other things related to that anxiety that you might want to be able to go to therapy for. And also, really, when we're talking about psychotherapy, we're not necessarily treating autism. So there might be traits of autism. So for instance, some of the rigid thinking or the black and white thinking. So a lot of my clients will come in and talk about, I'm just struggling because I think it's either I'm right and everybody else is wrong. And I don't know about that gray area. I don't know how to think about some of the other things. I can't think of a second way to solve a problem. And so in that case, we might say that we're kind of treating the autism, but it's not with the goal of at the end saying you are no longer autistic. It's really taking that one particular trait, or we're dealing with a co-occurring condition. So we're treating the anxiety, we're treating the depression, we're treating the trauma, but we're not curing autism. And I would never say, and I hope that none of you are experiencing this with therapists who say, I can cure you of your autism. Number one, autism doesn't need to be cured. And number two, that isn't the goal of therapy. Really, the goal of therapy is that we want our clients, whether they're children, whether they're young adults or adults, to be able to come into the therapy room and say, this is what I feel I need help with. This is what I would like to change, or this is what I would like to be able to cope with. So it's about what do they see they need. And they know, the individual client knows better than anybody else. So even though parents might feel my child needs to change this, or somebody else might feel like the child needs to change this, or the person needs to change it, it's really about what do they want to change. Because as a therapist, I don't really cause the change. It's not a magic wand. It's really through talking and activities, getting the client to see, hey, I do have the ability to change this, and I'm going to feel better if I do learn these new coping strategies, or if I learn how to handle my trauma. But it's not up to me ever to set the goals or to tell a client what they need to change. The client needs to come in with that. So motivation in therapy is a key. If somebody isn't motivated to be in therapy, and I think there were some questions about this, if somebody isn't motivated to be in therapy, this type of therapy might not be right for them. There might come a time, it might also just be client-therapist match, that you really need to be spending some time to figure out what is the right match. And sometimes, as I'm going to talk about too, therapy doesn't have to be 100% goal-directed. It doesn't have to be, we have 10 sessions to cure your anxiety. It can just be, what do you want to talk about? What was difficult for you this week? What was successful for you this week? And let's talk about how you felt about the success, and start to focus on some of the positives and some of the good, because everything for some of our clients has always been focusing on the negative, what they can't do, what they do that isn't supposedly typical. And that is trauma inducing. So what about if we talk about, well, what was good? What made you feel good this week? And really exploring that and figuring out, well, how can you get that feeling more often in your life? So some of the beneficial strategies, and again, I have to go back and just say, there isn't one strategy. I wish I could say to you, hey, just do this, because all of your clients are going to be different, as you know. They're all going to come in with a different set of concerns and a different set of needs and a different way that you're going to need to come at helping them. But we do think, like I said before, that there are commonalities. So one of it's kind of two strategies that I've lumped together, cognitive behavioral therapy and dialectical behavioral therapy. They really have a lot of overlaps. And the idea here is that we're really going to be looking at some of the thinking patterns of our clients and trying to rearrange or change those thinking patterns that are leading to some behavior that isn't helping the client feel good about themselves or isn't leading to the outcome that they want. And dialectical behavior therapy oftentimes does very similar things, but will oftentimes include more of a kind of mindfulness mindset and includes a little bit more relaxation. I think narrative therapy, which I'm going to give you an example of in a minute, is very helpful for my clients who have experienced trauma. So narrative therapy is kind of putting things in story format, and that can be done verbally through telling a story. It can be done written. If your client likes to do that, it can also be done through cartooning, art, drawing. All of those are valid forms of communication in the therapy room. And with narrative therapy, we really are going to start off kind of just with just what are the facts, what happened, and then we go back and we retell the story with thoughts and feelings and everything, while including then, as we go back, some coping strategies and some ways to sort of close the book. And what I like in terms of doing therapy, and why I've kind of enjoyed it for as long as I have, is because I'm sort of always trying to think of, well, what are the ways to take some of these concepts and maybe make them visual, these abstract concepts, and make them visual. So a lot of my autistic clients have said to me that they really think more in pictures, that they need visual aids. And so my therapy is almost never just me speaking to a client. There's usually a notebook or a whiteboard or something right there where it's like, well, let's do a visual depiction of that. Let's draw that out. Let's put it in a term that you might understand. So, for instance, one of the examples here, the frustration triangle. This is something that I use a lot with clients where they might be feeling depressed or they might be feeling upset and angry about things. And it's like, well, what's making you frustrated? And so we talk about how, at the very tip of it, we have to be able to name it. I'm feeling frustrated. I'm just feeling angry. I don't like this feeling. And it's like, that's great. Okay, so now we know what it is that we're trying to help. And then we tame it. Then let's use a relaxation or a calming strategy. And let's pick and write in our box, what are the strategies that we want to be able to use? And then we reframe it. And the reframing is where the cognitive piece comes in. And that is, what's another way to think about this? So if the issue was, I really wanted to play with that toy and another kid took it before I did, and now I'm angry, it's like, well, what about the fact of, you know what, tomorrow I'm going to be able to play with that toy, or maybe we can share the toy. So reframing is a way to be able to think about, well, what are some more positive ways to look at this? What are some more active things that you might be able to do that don't necessarily involve grabbing the toy away from somebody, but rather rethinking and changing the way that you think about it. So we'll do that. Visual aids for breathing techniques. Oftentimes we talk about deep breathing with our clients. We also know that most people don't know how to appropriately do deep breathing. And I know we had another webinar on anxiety specifically, and I encourage all of you that are really interested in some of these techniques to watch that webinar too. But there's all different types of visual ways to think about deep breathing so that people are really going in through the nose, holding it for a second, and breathing out through the mouth. And just calm. Being calm is also an abstract concept, because the fact is most of the time we tell people to be calm when they're anxious, and we almost always forget to label when somebody is calm. So when, as a clinician, as a parent, as a teacher, we say you need to calm down, I think a lot of times what happens is our clients don't know what that feels like because we haven't labeled it yet. And a lot of our clients have difficulty labeling their own emotions and their own feelings. And so we need to be able to help them with that in order for them then to be able to say to us, well, now I am calm. That deep breathing did work. That mindfulness activity did work for us. I'm a big proponent of play therapy, and play therapy for me is not the traditional insight-oriented where a child plays and I'm going to make assumptions about what it is that their play meant. It is really about just that opportunity to play with me in the room so that you can feel comfortable and validated, and so that through our play, I'm slowly going to be doing some therapeutic things that a child wouldn't even realize is therapy. So when you have a 10-year-old maybe who says, I don't want to go to therapy, it's like, well, that's great. Let's come in and play with Legos. We don't need to do talk therapy. We can do therapy through Legos. We can talk about all kinds of different things. We can talk about how in order to make a building strong, we need a really strong foundation. And what does that mean? How do you build a strong foundation for yourself? How can you become the biggest Lego and be able to support all of these other things? And we can use anything like that in order to help build up skills. Systematic desensitization is that concept of taking something that is really overwhelming or anxiety provoking and breaking it down into little itty bitty components and systematically helping the person be able to cope with that strategy. I use systematic desensitization primarily for sensory overload issues. And I'll give you a very quick example. I had a client who, for whatever reason, just was very bothered by the Beatles. It just set her off. Her whole body would be like electrified. And she couldn't go anywhere where the Beatles were played. And she came in therapy and said, I know that this is going to happen. Everywhere that I go, people like the Beatles. They want to play the Beatles. I go out to a bar or something, and the Beatles are going to be played. And I want to be able to cope because I want to be able to go to these things. So we started off therapy where the Beatles were on, like on the iPhone, but it was muted. So the client knew it's there, but couldn't hear a thing, and was able to go through therapy while feeling relaxed. And slowly we turned the volume up, and we turned the volume up. But to be honest, we never got to the point where the client felt comfortable listening to the Beatles very loudly. And so instead we said, okay, let's figure out, if you are someplace where the Beatles played, what is your coping strategies to be able to do that? And ultimately, the client was able to, we decided to just say, you know what, I need to go to the bathroom right now, or I need to step out for a minute, and was able to just go away, knew the song was going to last about 3.5 minutes, able to come back when the song was over. And so that was the coping strategy. And one of the things I want you to take away is, again, it wasn't my role to say, well, you have to be able to tolerate the Beatles. It was, let's see how much you can tolerate, and if we can't get there, then what are the accommodations that we can make to the environment? And in fact, this client actually once went up to a bartender and said, is it possible for you to turn that music down because I am feeling overwhelmed? And the bartender luckily said, absolutely, and turn the music down. So there are ways, and you want to be empowering your clients again to be thinking about, what do I need and how can I advocate for myself so that those accommodations can be made? And if it's not a place where an accommodation can be made, how can I still feel comfortable in that environment? I also really encourage you to try and brush up on your client's interests. I use my client's interests all the time to try to explain issues and put things sometimes in a vocabulary that they might understand. So I have a client, this was a client who had intellectual disabilities and was verbal, but didn't have age appropriate, age expected verbal skills, but was an amazing artist and was very into Looney Tunes and drew a variety of Looney Tunes characters for me. And we would just talk about the different emotions, and the client would be able to kind of point to, well, today I'm feeling, like the road runner. I feel like I'm all sped up, but never had to say to me, I feel like I'm all sped up, because they weren't able to use that language. But I knew when they pointed to the road runner that that's what that meant. And so we were able to then work on some calming strategies in those particular cases. And they might point to one of the characters who was sad. And then I knew, okay, you're feeling sad today. Let's talk about different ways that we can try and make ourselves feel better. So understanding their interests and being able to sort of bond with them, because the most important thing, I think, in psychotherapy is rapport. You have to have rapport with your clients, and your clients have to feel like you're there and you're interested in them. And that way they feel like it's a safe place for them to open up. I would encourage everybody to step away from manualized protocols. So anything that says, here's a 10-week program and everything will be fine in 10 weeks. I find that typically I need to be modifying that curriculum, and everybody doesn't move at the same pace. And so with manualized treatment, you have to be, I think it's great to use it as a structure and a foundation, but you always want to be ready to sort of expand upon it. And then finally, you want to take a non-judgmental stance. Once again, it is not up to us to sort of decide what our clients should be liking or not liking. I can't tell you how many times people have said to me, I just want my son to get married. And it's like, well, not everybody gets married. Not everybody in the world gets married. That doesn't necessarily lead to happiness. So it's not up to me to say, well, this person absolutely has to be married. Or for instance, another thing, I had a client, a 22-year-old client, who really loved Big Bird and liked to wear clothing that had Big Bird on it. And mother had said, this is so inappropriate. He's 22 years old. Could you please get him to not be wearing Big Bird anymore? He needs to see that this is embarrassing. And I thought, but it's not embarrassing. That's what he likes. And so I'm not going to take a judgmental stance. And we talked about, liking Big Bird, or what are some things in Big Bird socks, and what would happen if somebody said, aren't you too old to like Big Bird? And instead of saying, don't like Big Bird, let's talk about how can you respond to some of those things, or how can you make other people's judgments maybe not bother you as much. Okay, so I'm going to give you a couple of examples in my waning minutes, and I apologize if I'm speaking too fast, but I'm trying to get a lot in here and still make sure that you get the opportunity to hear from Sid directly. So a quick example about play and how I utilize play therapy. So I had a client who was 3.5 years old when he first started with me, and had some language, but certainly not conversational language, and was very interested in spinning water, really liked just to sit around and spin water. And of course was sent to me like, well, he can't do this in school and everything, so you need to get him to stop. And I thought, well, I don't think that's what I'm supposed to do, because clearly the client was enjoying the spinning water. So let's figure out if somehow we can add to that. So this client would come in, always made a beeline for the bathroom, and wanted to spin water. The other thing that the client enjoyed was I had plastic animals, and enjoyed when I labeled the plastic animals, and oftentimes like to echo the name of the animal. So as the child was spinning the water, I said, hey, elephant. And I threw the elephant in, and I was, oh no, no, the elephant is going to go down the drain. And the client thought that that was pretty funny. And then the client looked at me, and I took that look to be throw another one in. So then I started labeling the various animals, and we threw them in, and they were all swimming, and it became a jacuzzi, and oh, it's too hot, let's all jump out. Oh, it's too cold. And then eventually the client started labeling the animals that he wanted me to throw in, which I did. And eventually this expanded to an entire play repertoire where the animals were going to the beach, or they were going to a birthday party, and they would jump in and have competitions who could land in the water from the farthest, and we were throwing the animals all in and everything. And the great thing about this was, without me ever having to tell the client, do this or don't do that, the client turned around at school and went up to another kid and say, let's play pool party. And now the client was able to play in a more functional manner. But remember, the functional and play is fun. Play has to be fun. But the client was able to do that. So that to me is therapy. And we didn't need to be talking about feelings or anything like that. I was just helping expand the client's repertoire, but without ever telling them you have to do this. It was all organic. An example of anxiety that I think is kind of the way that I mostly like to address anxiety with a lot of my clients is take something that they're really familiar with and use that as something that maybe has a scale or a gradient, and use that to talk about rating your anxiety. And this would work for depression and some other things too. So for instance, I had a client, again, this was, he was about 16 years old and did have an intellectual disability. However, special interest was light bulbs, and knew tons about light bulbs, and understood that a 40-watt bulb was not as bright as a 100-watt bulb. And so we talked about situations and anxiety and what light bulb went off in his body. Was it only a 40-watt, which meant it was very low light, or was it a 150 three-way watt bulb? And these were just things that we couldn't talk about. And then we did strategies. So what are the things that you can do to help calm yourself? And we practiced all those strategies. And in the end, we wound up with the concept of a three-way bulb, where he was feeling, I always forget three-way bulbs, I think it's 50, 100, and 150. And I was like, okay, you're 150 right now, let's get to 100, and then let's get to 50, because you really can't go from 150 wattage to 50 wattage. We have to go down systematically. But so we'll use these kind of things, whatever the client understands and makes sense to the client, we're going to use that. And then we're also practicing constantly anxiety techniques. So we're practicing deep breathing, we're practicing just being in the here and now, we're practicing deep squeezes, we're practicing yoga, if that's what the client likes to do. We're practicing all these different things that can be done to help the client calm down, and then we're reevaluating where was your anxiety at that point. So now anxiety that is an abstract concept is visual to this client, and they understood it, and they were able to then implement many of these strategies on their own. So a few things for depression that I want to mention is I think a lot of the depression for autistic people comes from this idea of kind of feeling like, well, there's something wrong with you, right? You're broken. I have many clients who have come to me and said, you know, I'm broken. And I say, actually, you're not broken at all. People are making you feel that way, but let's get you to accept yourself. Let's get you to understand how great you are and how valuable you are out there in the world and to other people. And wearing of the mask. So I think a lot of you who are familiar with autism or read a lot of what autism people themselves talk about, that wearing of the mask, trying to pretend that I'm neurotypical or non-neurodivergent, and the weight of those masks just becomes incredible. And oftentimes I talk with my clients about like the suitcase that they're dragging along, this whole idea of, well, you know, I can't say that this is too loud, and I have to be able to wear this dress because of whatever, and I have to do this and I have to do that. And just you're constantly carrying all this baggage. And then again, you have that built-in sort of ableism that's been coming at you for many years, and feeling like you're isolated. Like, I don't know other people like me. I don't know how to get along with other people, and nobody accepts me. all of that can lead to depression. And so one of the things that we do is we do a lot of cognitive behavioral therapy in this aspect about, well, what are the good things about you? What do you like about yourself? And how can we celebrate those? And how can we find those people who are going to celebrate them with you? So I'm going to give you a really quick example. A client, about 15 years old, had a special interest in ceiling fans from the time they were very young, and knew a lot about ceiling fans, but really just wanted to talk about ceiling fans, and felt like they couldn't because they were told that's not normal. That's nobody else, no other, 16-year-old boys want to talk about autism. Want to talk about ceiling fans. And so when the client came to me, they said, I can't find any friends. I have to stop liking ceiling fans. And it's like, no. Let's, we talked a lot about ceiling fans. What does he like about ceiling fans? Why does he like them? What are his favorite ceiling fans? And then I said, you know what? I'll bet we can find a group of other adults, young adults, who like ceiling fans. And sure enough, we went on Facebook and we found 5 separate Facebook groups that are just related to ceiling fans and people. And these are all young adults to adults who still like ceiling fans. And so I encouraged the client. We worked on, how to join the group. We worked on maybe what is the introductory post to make. To introduce themselves to the group. And afterwards, the client came back to me and said, I have found my people. And the client has now remained for 4 years active in these groups, has gone to a ceiling fan convention even, and feels like, you know what, it's okay that I like ceiling fans. That's not a bad thing. I don't have to stop. I still belong in this world, and I'm still a good person and a likable person and a friendly person, and I can like ceiling fans. And then finally, as I mentioned before, about trauma. One of the things I think that really helps with trauma, again, is this concept of using narrative therapy. Narrative therapy can be traditional journaling, like bullet journaling, which can help a lot with trauma. But also, with my clients, I often like to talk about, let's tell the story and let's just kind of tell the facts. Again, with a lot of my clients who have experienced trauma, it isn't necessarily one event. So it's kind of going over what are the things to remember that made you feel like you were being invalidated or made you feel like you weren't worthwhile. And then let's add the feelings in. So first we're just going to write about or talk about those things. Then we're going to add in the feelings. Then we're going to add coping strategies. So what are the things that you did? What are the things that you can do now? How can you look back on this as an experience that doesn't have to have traumatized you? Because maybe now you have more self-acceptance. Maybe now you're understanding that it's okay to be who you are, and giving them coping strategies, again, to ask for accommodations that they might need, or just walk up. One of my other clients became comfortable to say to friends when she met them, I have a tendency to go on and on when you bring up a subject that I like, and please just tell me if I'm talking too much, because I'd rather know than have you walk away and say, I don't want to be your friend. Let me know, give me the feedback so that I know what works and what doesn't work. And so we work on all of those coping strategies. And then at the end, we talk about closing the story. The story has ended, and now we're at a new place where we can move forward from that place. And we can focus on all the positives and all the good. And for some people, they might not feel like there's a lot of good that they have experienced, but we're going to find it and we're going to celebrate it.
Dr. Stevens, are you ready to move on to Sid?
I just want to thank you. I just want to be able to just make sure that the takeaways from all of this, again, are that you are treating the traits that your client wants to change. Sometimes you're just being affirming. I had a client who said, why do I need goals? I just want to come in and talk to you about whatever I'm thinking that week. And that's absolutely fine too. I'm there just to be affirmative. And that therapy does not make somebody non-autistic. We're here to help our clients feel better, feel good, and to accept themselves. So now I'm going to turn it over to Sid Frank. And Sid was a therapy client for many years. And I think Sid is going to tell us a little bit about the beginnings of her experience in therapy, what it was like. And I'm going to turn it over now. Welcome, Sid.
It's so interesting hearing like the reason behind all the things you do. Because when I was younger, therapy is just something, you know, your parents made you go to, like the doctor or McDonald's. So like hearing the perspective on, oh, this is why you did this and that is very interesting. Because when I was very young, it's like I didn't know how to connect to people. I knew autism was the reason for it, but it's like I'd never been anything else. So I'm like, oh, everyone probably has a therapist. And it was the play therapy that really helped me to open up to others, because I had such issues like connecting with other kids. And with Lori, it was, she always and yes'd me. Just like in improv, it's like whenever I wanted to do something, she'd just say, yeah. And being able to make that connection with someone who would just say yes to everything was kind of nice in like the play environment. Because with other kids, it was so frustrating for me, because it's like I'd want to do something and they'd want to like interject or put their opinions in on it, which was terrible for me as an autistic kid, because everything was very black and white. And I'm like, no, this is how you play with dinosaurs. And having someone who was just totally down to, you know, play with dinosaurs or Barbies however I wanted was just so affirming. And I think having that affirmation later on when we transitioned to like talk therapy, it really built up, you know, trust. And there were also like, I was very interested in art, and I'm still an artist to this day. And like one of the things about like connecting with people is like making eye contact and reading body language. And I wanted to draw those things, even if I didn't understand them completely. And she would go over them with me like, oh, is this an angry eye? Is this a happy eye? Is this a sad eye? And through that, I actually learned about body language and maintaining eye contact and shaking hands and asking other people about their kids or whatever. And it was never forced. She was always she always worked with me and my interests. And I think if I had had someone who tried to impose their idea of normalcy on me, it just wouldn't have worked, because I had a lot of very strong opinions back then, and I have a lot of very strong opinions now. And again, having someone work with me, like it with my interests and those sort of things, really helped. Nowadays, even now, it's like I think back to the way we would play, and it's like, again, I took an improv class years later, and the stark similarities between your method of therapy and literal improv comedy is just, I'm just like one for one. Yes, it's the and then. And yeah, and it's like, I went through a lot of different phases when I was younger, and one of them when I just kind of, a little bit after I think I'd started working with her, I literally did not want friends, mainly because I was unable to form connections with people with the things I was interested in. It's like, oh, I'm interested in this, and nobody was genuinely connecting with me on that. So I'm just like, what's the point of friendship? You just have to fake it with people, and they fake it back to you. And she never, like, I don't know the right word, like degraded me for that. It was always like, okay, you don't want friends, that's fine. We'll talk about something else. And I think that was very affirming, because if excuse me, if I had talked to someone who's like, no, you have to have friends, you have to be, there would have been a very teenage pull away from that, because it's like, why? There's no clear reason for it. And eventually I met people who liked the same things I liked, and that, yeah, I'm like, oh, that's why people want friends, because they like the things you like, and you can talk to them about that, and there's a back and forth. And if she hadn't affirmed me at that younger age that it's okay to not want something just because everyone else has it, I probably wouldn't have gone on to have friends, because I would have thought, oh, I have to fake interest in other people, and having a genuine connection with people is less important than, like, having a genuine connection to people is less important than doing these social roles. And like later on, like I did see the importance of these social, like I make so much small talk with my boss about his kids. Like my level of interest in it varies from day to day, but it's important to him. And because I talked to him about that, he's willing to listen to me about like Transformers or whatever. Like I ended up convincing him to buy so many robot toys for his son. It's very funny. But it's like, in order to understand like the reciprocative nature of social interaction, I had to have someone yes to me in order for me to yes to them. And genuinely, I don't think I would have a job today or have been able to go to college if I hadn't had Lori say yes to me back then. Because it's like, when you're on the spectrum, you hear no so much physically, emotionally. Like, you just look at, like, I'm going to say one story from when I was talking to Lori, and it's rejection sensitivity is such a thing for autistic people. And the thing that happened was, I think I was like maybe 10, and I'd gotten one of those little tin of peanuts with like the little springs in it. And I was so excited because, you know, I'd seen this on TV. I know how it plays out. You walk up to someone and say, "Hello, would you like a salted peanut?" And they open the jar and there's a surprise reaction. I walked up to someone, I think it was the help group actually, and I said, "Would you like peanuts?" And they said yes. And I opened it and the springs came out, and they acted surprised, but they weren't actually surprised. And I think that genuinely was heartbreaking for me, because it's like, I know the script, I know what's supposed to happen, and I didn't get the reaction that I was supposed to get. And it was just like, even though she acted surprised, I could immediately tell, no, she's faking it. And that was heartbreaking for me. But I also think if I hadn't gone through that, I wouldn't understand that, no, most of the social things we do are, you know, a bit play acting, even though we like that there's a certain amount of real behind it. Like, when you're on the spectrum, most of it is going to be play acting because you're just not interested in this stuff. And learning how to make yourself interested, or learning if you act interested, they will be interested in what you're doing. It's that back and forth that really helps. And even learning how to like make phone calls and all this. I went through so many scripts with Lori of just like, what do you do when you're on the phone? What do you do when you get the secretary for someone on the phone? If you're having a panic attack because you accidentally got the secretary, what do you do then? And it's like, most of my fear from a lot of these situations wasn't in actually talking to someone. It was in like, what if they say something and I don't know how to respond? It was hitting that wall and just not knowing what to do next. And honestly, the only way to get past that is just to do the thing and say, oh, I just fall down on the floor and cry for a little bit. And then someone says, it's okay, let's try again. And you're like, okay, I can try again. And
Sid, I'm sorry, absolutely fascinating. And I think it was very helpful. I just want to make sure that your mom has a chance to pop in before we run out of time. So Deborah is Sid's mom, and Deborah's just gonna really briefly share a little bit about kind of how Sid's therapy. Deborah was not a therapy client, but parents are always an active participant and are included. So Deborah's just going to talk a little bit about her experiences and coming to understand who Sid was as an autistic person and accepting her. So Deborah, we'll turn it over to you for just a couple of minutes. I know we're running late, and I appreciate everybody being able to stay a little bit longer. So it means a lot to us that everybody's willing to stay. Go ahead, Deborah.
Hi, welcome everyone. Thank you so much. What a terrific conversation. I wish I had it when Sydney was younger. Anyway, Lori was an absolute godsend. I just have to back up. I heard her speak at the help group, and she wasn't taking clients, but I convinced her to, and that was when Sydney was in 4th grade. And that was a whole interesting another conversation. But the gist of it was, I think as parents, at least for me, I had a certain notion of what I had anticipated my child was going to be like. And I'm a very strong person, and it had to be my way. And guess what? When you have children, as you know, as therapists or parents, they come out a certain way. And for me, it was challenging, but it was the best thing ever. What made my way so right? And hopefully Sydney will agree as an adult. I mean, I think there's still that push me pull you going on, which I call, like when the child lives in the house, even if there's an adult, sometimes you revert back to that parent role and that child role. So it was very hard, had many conversations with Lori, but thank goodness I acquiesced, because my husband and I don't look at Sydney just as, oh, she's an autistic person. We look at her as a gift, and her qualities are her strengths. And I think in anybody, like that old saying, birds of a feather stick together. we never had those labels when I was growing up. For example, not to veer off topic, but I didn't realize I had ADD. You can probably tell by my gestures and how I'm talking. And for me, I've also learned that other parents discover things about themselves. So that was also a window of opportunity. And I look at life and I look at my daughter as a teachable moment. Okay, here's a good example. She could not for the life of her figure out her math figures or times. And I did Schoolhouse of Rock and I posted them on the wall and we sang songs and I did a litany of things. And after a while, I'm like, screw it. Just let her use a calculator. Who cares? And now look, everybody has computers. But when she went on a trip to England with my mom, this is the Harry Potter days, she could change currency in her head. So go figure. It's like a kid who doesn't have to do the math and show you everything. They just have the answer. Who cares if they're getting it? And that was the best thing for us, is teach her to her strengths. And I think that's what everything that Lori has talked about, take that area of interest. It's that circle and a square. So did I hopefully encapsulate all of that in a few minutes?
Yes, thank you. That was great. So I'm going to hand it back over to Dr. Bolton now. And
I don't even know what to say. Lori, Sid, Deborah, so amazing. We should have scheduled this for 2 hours and a half or something. And I don't know, maybe we'll figure out a way to come back to this, because the chat is really sort of overwhelming with positive emotion, and so much gratitude and continued interest in this. So I can't thank the three of you more. I do want to tell everyone, because there have been a few questions that are, just about how do we access services. So we've answered a couple times in the chat about how to get to Lumina. But the easiest way is there you go. But the easiest way is to make the call. It's 818-779-5100. So you can make that call to Lumina to see if services are appropriate or how we can match you with a therapist. Also, folks are very concerned about being able to see this again. So it will absolutely be posted on our website. We know everybody who's registered, so we will get back to you about when it is available. And like I said, we will be thinking about maybe how to do some more similar kinds of things in the future for everyone. There are also some questions that we will answer for people offline, because there are some important questions I want to make sure that we get to. So please don't think that your questions will go unanswered. Our entire chat is saved and we will know everything that everybody asked today. So we have come to the end of our time and more. Again, thank you so much. Please save the date for our next scheduled webinar, which will be on May 25th. At 10 a.m. Pacific Standard Time. For those of you in the UK, you'll have to get out your calculators and figure that time difference out. The topic will be Life Illuminated, Positive Psychology in Practice. And again, we will reach out to everybody who registered for this event to let you know more about that information. At the Help Group, we always endeavor to provide the best education to our students and to impart what we have learned about best practices to parents, other schools, other communities, and other professionals. If you would like to learn more about our schools and programs, you may go to our website at www.thehelpgroup.org. You may email our admissions department at admissions@thehelpgroup.org. You can give us a call at the number that I said for Lumina, or you can give us a call at our main number, which is 877-943-5747. Thank you so much for joining us. We appreciate you choosing to spend your valuable time with us today. We at the Help Group are here for you when you need us. Have a great rest of your day. Bye-bye.